Okay, thank you very much. I'll be talking about vertical abnormal head posture. This is not a vertical upward drift, it's a vertical abnormal head posture in nystagmus. So if you look at nystagmus, there are different slow phase and a fast phase, and sometimes it's out of control. I hope none of us are sleeping in the morning. I just wanted to show this. So when you have eye movement, something we have to record it. Can you see when the patient is looking at different things? The eye movement really records everything. So in that fraction of a second or a minute, everything is charted from each of those. This is one of the experiments we did in patients with congenital cataract versus the normal patient. You can see how many times the people have to scan. So same thing happens in nystagmus when you have a patient. You all know about SIMAS classification. I'm not going into the details of that. But just when you evaluate, because vertical abnormal head posture is not just that, we have to evaluate the strabismus and the nystagmus. In the clinical evaluation, there is something called person's visual acuity and the eye's visual acuity. We are more concerned about person's visual acuity. When you check one eye, it could be poor. But I have this table which you have to do it in every patient. Then you can give it's a kind of 3 by 3 table where you have to, you can have face turn, chin down. I am basically talking about chin down and chin up. For vertical strabismus, you can tackle all the 6 muscles. Usually for horizontal, we take care of horizontal muscles, except some of the obliques in third nerve palsy where you can do a superior oblique anterior transposition. Here, you can deal with all 6 muscles. They can have face turn, chin up, chin down. Head tilt also can be there in some of the patient. And this is what we really do in essence. I will show 2 case examples for this presentation. What this child has, it's pretty clear, right? She has a very large head tilt, very large chin elevation, and she has a very large face turn. This is a multiplanar, and this is a multiple abnormal head postures are there. Vertical component has a very significant. What do you do? Whatever you do, look at the most important. What she had was, she got an inferior rectus recession, and also she got Kestenbaum for the horizontal. Look at this stage what happens, because if you try to do everything, because sometimes just 2 procedure can correct the other thing also. In spite of that, you can see she still had some abnormal head posture in the form of chin elevation. And then we could get her into an abnormal head posture where she had some more chin elevation. What we did at this stage is superior oblique tenotomy. There are 2 schools of thought for vertical abnormal head posture. Either do a resect of the inferior rectus and the superior rectus, or do a yoke muscle surgery, inferior rectus and also superior oblique, or superior rectus and also inferior oblique. So this is the very good, because it gives a very symmetrical correction. So as a second procedure, she had the procedure of superior oblique tenotomy on both sides. You can see lid is retracted there because we did a large recession. So this is for chin up. I think Dr. Hertel has a very, very good paper on that. I do a combination of resect and oblique. Dr. Hertel always recommends either a resect, one of the muscle recession, and always include oblique. I asked him why he includes all the time oblique. He says oblique tenectomy is a very symmetrical surgery. When you do a recession and the resection of the vertical rectus muscles, they can cause some kind of torsion, which I will share one more case which I did not see that particular thing. So this is for chin down position. Most of the times chin down is seen in albinotic patients. If you see them, they will not say, but if you look at their video, they will always be the video from the home, they will be always like this. So this is a very, very good surgery where you can do inferior oblique myectomy, complete myectomy, as well as superior rectus recession. So this guy came with the chin up position of 50 degrees. The parents saying that he is not playing with iPad like his friends. That's what their situation. You can see the 9 gaze pictures, no strabismus, fortunately. Nystagmus with vertical abnormal head posture. I'm not going into the details of the vertical nystagmus, when to scan, when not to scan. All that is a different topic. You can see this guy, this is the pre-op and that's the post-op. So what he had was very, very significant. There is no way he can study this guy because he was told that nothing can be done for this. What was done was he had a resect procedure of 6 and 6 millimeter on both sides. And this is what he is after the surgery. You can see he is watching TV. He is okay. He is playing like normal kid after this particular surgery. So you have an option of doing enlarge 50 degrees, resect, or include one of the oblique muscles. And the last part I wanted to cover, which I really spoke in WSPOs, was the tilt part. When patients have tilt, what do? Simple mnemonic, because of the want of time, raise the right-sided rectus muscle on the side of the tilt. For example, if somebody has a right head tilt, what do? Raise the lateral rectus on this side and raise the medial rectus on the other side. And same way, lower the other muscles. So that's what we did for this particular patient. You can see basically intorters will be there. You have to make it extorsion by doing the simple surgery on the horizontal muscles. Here we have an option of doing horizontal muscles or horizontal displacement of the vertical rectus muscle or even oblique muscle. So this is what we had, 3 patients you can see, simple vertical transposition of horizontal rectus muscles. We got those results. One of the advantage of horizontal muscle is even if they have any kind of abnormal head posture in terms of face turn, you can take it at the same time. And always try to have eye motility recording if you have, but otherwise you can use this thing. That's all I wanted to show. I just want to invite you all for this POSN meeting and also Eye on the Future meeting in July, and also Copenhagen for the WSPO Subspecialty Day. Thank you very much. If there are any questions, I can take.
Yeah.
I have never done it because I always got this. If I don't get the adequate result by vertical transposition of the horizontal rectus muscle, I go for oblique muscles. Because once I touch the horizontal, I don't want to touch the vertical because of the anterior segment ischemia. I have a couple of cases where I have done as a secondary procedure. I have weakened the superior oblique intorter on the side and I weakened the inferior oblique on the other side, which we have got a good result. So somebody asked me what is the gradation for the head tilt. If it is around 10 degrees, I do half muscle width. If it is more than 10 degrees, up till 20 or 25, I do the full width transfer of the horizontal rectus muscle. But I have experienced if it is beyond 30, you will always have to add one more muscle. Yes. As a second option. Yes. Yeah.
Vertical transposition of one muscle in one eye does not give you any patterns?
No, no, it won't. It won't give any patterns. We never do one muscle. It's
No,
always.
you do one eye here, or you do a recess of one eye and a recess of, or just
I always
you
do
don't
4 muscles. I always do 4 muscles. It's not just a 2. Yeah. Again, the angle of deviation. I am getting very good results with the recess resect. That's my primary choice. Depends upon the degree of deviation. Like that child had 50 degrees of chin up. I resected more in that patient. Thank you very much.
Yeah. Thank you, Dr.